Podcast 13 of the Upper Limb series. Common injuries of the upper limb. This is the final podcast in the Upper Limb series and is going to detail some of the common injuries associated with the upper limb, with particular attention being given to nerve damage. Nerve damage throughout the upper limb is going to result in weakness of the innervated muscle and a loss of sensation from the corresponding area of skin. So let's detail some of the major nerves associated with the upper limb and how they can be damaged and the consequences. The easiest way to appreciate the likely outcome of nerve damage is to try and remember the muscles and skin innervated by that particular nerve, because damage to that nerve is going to result in a predictable loss of function. So let's start with two nerves that supply muscles in the trunk and shoulder region, the long thoracic nerve and the auxiliary nerve. The long thoracic nerve runs superficially along the thoracic wall to supply serratus anterior. Due to its superficial location, when the arm is extended and abducted, the nerve is vulnerable, and during a knife attack, the long thoracic nerve can be damaged. As serratus anterior is involved in clamping the scapula to the thoracic wall, paralysis can cause the scapula to lift away from the thoracic wall and appear to float in the skin of the back. This feature is particularly evident when the person is asked to push against a wall, when serratus anterior would usually protract the scapula. Due to its paralysis, it is unable to do so and is forced posteriorly, and this is known as a winged scapula. The auxiliary nerve is a branch of the posterior cord of the brachial plexus and supplies the deltoid muscle and a small patch of skin on the lateral aspect of the proximal arm. Due to the course of the auxiliary nerve, it can be damaged in numerous places. As the auxiliary nerve leaves the posterior cord, it travels through the quadrangular space, which, if you remember, the quadrangular space is formed by the long head of triceps, teres minor, teres major, and the humerus. It then runs towards the deltoid muscle by passing inferior to the glenohumeral joint and runs around the surgical neck of the humerus. Therefore, the auxiliary nerve can be damaged during dislocation of the glenohumeral joint, fracture of the surgical neck of the humerus, and also if the muscles that form the quadrangular space significantly increase in size, then the auxiliary nerve can be compressed. If the auxiliary nerve becomes compressed or severed, then the deltoid muscle will atrophy, resulting in a weakening of the muscle, and the person may not be able to abduct their arm. The patient would also experience a loss of sensation from the lateral side of the proximal arm. So now let's turn to the four terminal branches of the brachial plexus: the musculocutaneous nerve, the radial nerve, the ulnar nerve, and the median nerve. The musculocutaneous nerve isn't commonly damaged, but again knife attacks in the auxiliary region can cause weakness of the muscles in the anterior compartment of the arm. This weakness can lead to poor flexion of the elbow joint and also a reduced ability to supinate the forearm. However, these movements are not completely lost due to brachioradialis, which is a weak flexor of the elbow joint, and supinator, which can help supinate the forearm, are both supplied by the radial nerve. Alongside the muscle weakness, the person may also experience a loss of sensation from the lateral surface of the forearm. This region is supplied by the lateral antebrachial cutaneous nerve, and this is a direct continuation of the musculocutaneous nerve. So now let's turn to the radial nerve. This nerve is most commonly damaged as it runs alongside the radial groove of the humerus, so fractures in this region can lead to the nerve being severed. The consequences of radial nerve damage are paralysis of triceps brachii, brachioradialis, supinator, and also the extensor muscles in the posterior compartment of the forearm. The characteristic clinical sign is wrist drop, where the wrist and fingers assume a flex position to the unopposed action of the flexor muscles, which are supplied by the median and ulnar nerves. So now let's turn our attention to sites of potential median nerve damage. The median nerve is usually damaged in two places, at the elbow and at the wrist. If the median nerve is damaged in the elbow, as it passes lateral to the brachial artery within the cubital fossa, then there will be widespread sensory and motor loss of both the forearm and hand. Specifically, the person will be unable to flex the proximal interphalangeal joints due to the paralysis of flexor digitorum superficialis and flexor pollicis longus. And as the median nerve also supplies the lateral half of flexor digitorum profundus, the second and third distal interphalangeal joints will also be affected. As the median nerve supplies the first and second lumbricals, flexion of the second and third metacarpophalangeal joints will also be lost. This degree of muscle paralysis is evident when the person attempts to make a fist, which usually means flexion of both the interphalangeal and metacarpophalangeal joints. But as the muscles are paralysed, they remain extended, with only the fourth and fifth fingers flexing due to the ulnar nerve supplying the medial half of flexor digitorum profundus. So extension of fingers 1 to 3 and the flexion of fingers 4 to 5 when trying to form a fist is known as the hand of Benedict, and this is a classic sign of median nerve trauma. The most common site for median nerve damage is in the wrist, as it passes through the carpal tunnel. A reduction in the size of the carpal tunnel due to inflammation or infection of the tendons that pass through the carpal tunnel can compress the median nerve against the tough flexor retinaculum, which forms the roof. Compression of the median nerve will result in a loss of sensation from the lateral 3.5 fingers on the palmar surface of the hand. Importantly though, the cutaneous supply to the palm of the hand will be spared, as the palmar cutaneous branch lies superficial to the carpal tunnel and will therefore be unaffected. With time, a progressive loss of thumb coordination will also become evident, as the recurrent branch of the median nerve that supplies the thenar eminence will also become affected, resulting in muscle atrophy and an inability to oppose the thumb. This loss of sensation and muscle weakness due to compression of the median nerve as it passes through the carpal tunnel is known as carpal tunnel syndrome. The symptoms can be relieved by cutting the flexor retinaculum and releasing the pressure, a procedure known as carpal tunnel release. So the final nerve I want to detail is the ulnar nerve. This nerve is commonly damaged in 3 places: at the medial epicondyle, within the cubital tunnel, and again at the wrist. The ulnar nerve is commonly injured as it passes from the arm to the forearm by passing around the medial epicondyle. In this position, the nerve is lying superficially and is vulnerable to damage when the medial elbow hits a hard surface. Compression or injury to the ulnar nerve results in loss of sensation from the medial palm and palmar surface of the medial 1.5 fingers. Damage will also lead to severe motor defects of the hand and wrist. There will be an inability to adduct the wrist due to the paralysis of flexor carpi ulnaris, with the wrist deviating laterally due to unopposed action of flexor carpi radialis. As the ulnar nerve supplies a series of intrinsic hand muscles, the person will also have difficulty forming a fist, as the 4th and 5th metacarpophalangeal and the distal interphalangeal joints remain extended. The unopposed extension of the 4th and 5th fingers when forming a fist is known as claw hand and indicates damage to the ulnar nerve. It is important to remember though that there will be slight flexion of the 4th and 5th proximal interphalangeal joints due to flexor digitorum superficialis being supplied by the median nerve. A similar loss of function would be experienced if the ulnar nerve is compressed in the cubital tunnel, which is the tendinous arch that connects the 2 heads of flexor carpi ulnaris, and also as it passes through the ulnar canal, which remember lies superficial to the carpal tunnel at the wrist.